Hello and welcome to our preview session for our live education program that is starting at WellMedic in August 2025, and it's going to be for the first sitting, which will then be the October 2025 sitting. My name is Dr. Mahmood. I'm the primary GP educator at WellMedic, and we've been helping GP trainees with their medical education, both AKT and now SCA since 2020. We also help trainees with their portfolio as well. Now, we've helped tens of thousands of trainees through the program, both in the UK and internationally. Now, one of the things that we started in 2024 was a AKT coaching program. So we realized that there were trainees that needed support on a more one-to-one basis. And generally, this was for trainees that had failed the exam either once or more than once, many unfortunately being in their fourth and fifth attempt of the AKT. And within that coaching package, especially our results in the last 12 months from recording this session, we've had a 100% pass rate for the AKT for our trainees. So what we're doing within the coaching has really helped, and prior to that, even without the coaching, our results have always been very, very high. So here you can see an example from Dr. Yana, who managed to increase her AKT score by 40%, which is massive. So the team and I kind of sat down earlier this year and we thought, how do we make this more accessible? How do we bring this kind of one-to-one element to a slightly bigger cohort, but at a better price point? Because of course the coaching is indeed expensive, because it's one-to-one time with myself or one of the other educators. So we've tried to come up with a plan for our live clinical education and stats, given that those are generally the two areas that trainees struggle with the most. And we are actually launching this program now, and we feel that we've reached a balance that we can provide this type of education at scale, but at a reasonably competitive price point. So as you can see here, from very recent trainees in May of 2025, we've had some really, really good feedback in terms of what they achieved in the exam. So this result was excellent, and we had lots of these emails. Similarly, this was from last year, again, excellent results for the AKT. So if you do want to understand and make that process easier for yourself in terms of passing this on your first attempt, or giving yourself the highest chance of passing the AKT, then please do stay tuned for the next hour or so as we break down what you could expect with some actual AKT education. So what is this live education program, and what are we planning to do? So as you know, the AKT package runs on a pre-recorded and flexible basis. So we don't require you to attend weekly sessions at the moment. You can just sign up for our package, which gives you access to revision materials such as the BNF summary, clinical guides, a question bank, a 20 question tool as well, where you can randomize questions from the bank. We have a mock exam, actually 2 mock exams with video explanations. We have a pre-recorded stats and evidence-based admin course as well, where you get full curriculum coverage. So there's plenty to get your teeth stuck into, actually, 20, 30, 40 hours worth of content on the website alone. This live education session is going to be launching in August, and what will happen is you will get 1 hour of clinical education. So we'll take a theme like respiratory, cardiovascular health, gynecology, pediatrics, and we will run through areas that you can apply yourself and learn from the process of application of guidelines, and what types of things you may need to consider when revising for the AKT. So a bit more of a high yield approach, something that we actually haven't done before, but something that we have done within our coaching sessions. And then we're going to do 30 minutes of stats, because stats is really important, and if you can bring that stats score up significantly, then actually it's going to make your exam much easier as well. So we'll go through some examples of both today. Now, there is a limited time offer for this, in the sense that there are only 50 spaces up for grabs. So although you can't sign up straight away, you can pre-register with a deposit, and we'll put you onto the waiting list. But once those 50 spaces are taken, then that will close until we open up for a second batch. And the price point is $300, which we feel is very reasonable, considering that our package alone is £120. So for £10 a session, you'll be getting weekly high quality AKT education. So this session is really just to give you a taste of what you can expect, but hopefully you'll take away some good asthma learning, some statistical calculation learning as well, but also some learning for what type of graphs you may need to prepare for the AKT as well. As I said, there's 50 sessions or 50 spaces, so if you're liking what you hear and you do want to take advantage of this package, then please do pre-register, fill out the sign-up form, and there'll be a deposit payment, and after that you'll be added to our list. Of course, if the spaces run out, we'll close the form temporarily, or we'll take your deposit payment and refund it if further spaces don't become available. So the plan today is very much around asthma guidelines. So we're going to focus on asthma guidelines, both diagnosis and management. We're going to focus on scenarios, and we are also going to do some learning around calculations, just talk about how to ease yourself into calculations and why regular practice with our team will help. And of course, we're going to work on weekly graphs as well. So that's going to be the purpose and the way that it'll work. It'll be clinical for an hour, and then 30 minutes of stats split between calculations and graphs, just giving yourself the highest chance of passing the AKT. So let's just start off with asthma guidelines. So this first stage, or this first slide, really just breaks down what you need to know when it comes to the diagnosis of asthma in people who are 16 and over. So if you look at the slide, you can see the first thing that you need to look at is one's eosinophils and their FeNO result, and we'll come to what constitutes as a positive result just shortly. Then if that is negative, you then have the availability to do bronchodilator reversibility testing with spirometry, and we'll talk about again the results with that shortly. Now the third step is generally for two purposes. Either there is a delay in terms of getting spirometry or bronchodilator reversibility testing, which can be a very common scenario, or it's just not available. And if that's not possible, then you go to your peak expiratory flow rate, and we'll come through how to calculate percentages and how to actually counsel your patients on that. So again, this would be helpful for those of you who are preparing for the SCA as well. And finally, you've then got the bronchial challenge test, which is looking for whether there is any bronchial hyperresponsiveness. So this is a slide taken from the NICE guidelines. So if we just look at this slide now, you can see that if somebody has either a positive eosinophil count on their blood test, or their FeNO level in a person over the age of 16 is more than 50 parts per billion, then that's a positive result. You don't need to work on, you just go ahead and treat, as long as their history is suggestive of asthma. If that doesn't work, then you go to this kind of second stage, which is the reversibility testing. And ultimately, the reversibility testing, you're looking for that reversibility of 12%. It also needs to be an increase of 200 milliliters. And if you can't get that 200 increase, then you can look at 10% of what their predicted was meant to be. So the prediction is based on their height and generally their one's sex. And then, of course, you go on to this peak expiratory flow rate. So what does it mean by amplitude percentage of mean of more than 20%? So the amplitude percentage basically is the difference between the lowest result in the day and the highest result of the day. And if you've got more than one reading or more than two readings from the day, then you use the mean of those two results as well. And I'll come to that calculation very shortly. And you're looking at that average across the days of at least 20% or more. And finally, with the bronchial challenge test, you're ultimately looking for bronchial hyperresponsiveness, and if that's present, then again you can make the diagnosis of asthma. So all of this is really important. And why is it important in the exam? Well, ultimately, when you're thinking about exam questions, it's very likely that you could get a scenario of somebody who's got symptoms suggestive of asthma, and you can be asked what the first line investigation may be, which would either be kind of eosinophils or FeNO testing, or you could be given scenarios whereby somebody has had either a positive or negative test result, and you're asked what is the next step in that person's management plan. So let's say you had a patient who had a negative FeNO, but there's still symptoms highly suggestive of asthma, then you need to be thinking about the bronchodilator reversibility testing as well. So this is the kind of stepwise approach that you need to take when you're preparing for the AKT, is making sure that you understand how those things can be tested in the exam, and we'll go through some scenarios shortly. Now, before we do that, I just want to talk about spirometry in a bit more detail. So why is spirometry important? So spirometry is important because when it comes to analysing those reversibility tests, you could easily be tested on working out percentages, because generally working out percentages is a relatively straightforward thing that you should be able to do as a future GP. Although generally when you get the report in real life, it's all worked out for you, you just have to analyse the result. But given that there is the calculation of percentage differences and means within your evidence-based medicine component, then it's not unreasonable to get a question like that. So just a few things to mention here. Thinking about the FEV1, again, I'm not here to teach you how to suck eggs, but if you think about the FEV1, it's how quickly can you force air out in 1 second. If you think about FVC, then it's about how much air can you get out after taking one maximum inhalation and then one maximum exhalation. And then there's 3 patterns to recognize. One of that being normal, so if the FEV1 and FVC are both above 80% of predicted, that's a normal result, and the ratio needs to be above 0.7. In terms of an obstructive picture, so we're talking about asthma and COPD here, what happens is that FEV1 will go below 80%, and then if we look at the ratio can either be normal or it can be reduced, and if it's reduced then it's going to be less than 0.7, and generally the difference between asthma and COPD being is that there will be some degree of reversibility in asthma. Of course there can be with COPD as well, and that's where you get the asthma COPD overlap, and we're not going to discuss that today, but there is some information on the website about asthma and COPD overlap. And finally you've got your restrictive patterns. So this is restrictive patterns can happen for neuromuscular problems, they can happen in obesity, and of course they can happen in our interstitial lung diseases and that family of illnesses as well. So when you're looking at that, generally speaking, the ratio is normal, but the other levels are either normal or reduced. So that's the difference between those 3 patterns that we're thinking about. Now, the reason why I wanted to talk about these patterns were ultimately, if we think about calculations within the exam on that diagnostic pathway, and this is relative to both over 16s and people who are 5 to 16 as well, is that you should really be able to calculate those percentage differences. So if we look at this calculation here, if you look at the calculating the FEV1 reversibility, what needs to happen is you need to get somebody to do spirometry, you then issue their bronchodilator therapy, and then you repeat it 15 to 20 minutes later. And what you do is you calculate the difference between the post and the pre, and then you divide that by the pre-result, and then you times that by 100, and that will give you a percentage difference. So what I want you to do is I want you to pause the video here, and I would like you to calculate that level. So here we have a 25-year-old patient who reports daily wheeze and cough, waking 3 times per week with wheeze and a history of eczema, and therefore you've done that initial step which shows normal eosinophils, a negative FeNO result, so you have to move on to calculate that bronchodilator reversibility, and the expected amount for this patient was 2,300, so that would be 2.3 litres, and you've got a result of 2.1 litres and post 2.2. So there has been an improvement, but you now have to quantify whether that improvement is above the threshold, and just think about what that threshold is. So I'm not going to tell you. Of course you can rewind the video and have a look, but give yourself a moment, pause it, and then we'll go through the result together. Okay, so that should be enough time for you to now have had a crack at that calculation. So as you can see here, we've done the calculation for you. So it's 2.2 minus 2.1 divided by 2.1 times by 100, which gives you the percentage of 4.76. So for this person to have actually been diagnosed with that reversibility of 12%, they would have had to have a spirometry reading of 2.35, which wasn't the case, which would give them a percentage difference of 11.9%. So we could round that up to 12, I would say. And of course, there would have to be a baseline increase from that 2.1 to at least 2.3. So in ours, we've got a raise of 250 milliliters. So had they gone up by that much, then we could make a diagnosis of asthma with that reversibility. So I hope you found that helpful, and hopefully it just gives another element to how you can be tested in the exam when it comes to understanding common results that we will come across as general practitioners. Okay, so now we've got a situation where there's no bronchodilator reversibility testing available. So, we can take ourselves back to the pandemic where we were not doing spirometry, so it would have been very reasonable at that time to look at doing more in the way of peak expiratory flow rate testing. So when it comes to peak expiratory flow rate testing, there's a little bit of helpful information from Asthma and Lung UK, and actually the Asthma and Lung UK website is very, very helpful when it comes to looking at things like inhaler technique, how people should use EIR therapy or MART therapy. There's lots of valuable learning there from a patient perspective, but ultimately you can be tested on that in both the AKT and SCA as well. So I would say it's a very helpful resource. So if you think about when to test, the general guidance is that you test at 2 points in a day, first thing in the morning and generally around 4 p.m. That's when you are typically at your highest peak expiratory flow rate, and you take 3 readings and you take the best of the 3, and then you do that generally for about 2 to 4 weeks to get the most accurate results, minimum of 7 days. And there's a calculator that will do all of this for you on the Asthma Lung website. But if you were to calculate the readings, basically what you have to do is you have to work out a daily percentage score. So what's the variation in your peak expiratory flow rate in a 24-hour period? So what you do is you take the highest reading of the day minus the lowest reading. So that's fine if you're only taking 2 readings. If you've got more than 2 readings, then it's the highest plus the lowest, and then it's the mean of the highest plus the lowest. So how do we work out average? You take the highest, you take the lowest, you divide it by 2, and that becomes your mean, and then you divide the 2 and then you times it by 100 to get your percentage. So if I show you an example, which I will in a moment, just take a second. I'm going to show you a couple of graphs to look at. So you're not graph, a table. So here you've got a table of 7 days worth of spirometry. In one column you've got the AM reading, in the other column you've got the PM reading, and then on a couple of days, the person had a bit more time, so they did an extra reading. So what I want you to do is, if you just again pause the video and just make an additional column, I want you to work out what the daily percentage difference is for this peak expiratory rate reading. Now you're probably thinking, okay, is this reflective of the exam? Well, actually, from a statistics perspective, working out descriptive stats is really, really common. So you will get at least one descriptive stat. So again, you need to work out the difference between the highest and the lowest on the top. Then you would need to work out the mean of the highest and the lowest. So it's the highest plus the lowest divided by 2. And then you divide those 2 readings and then you times it by 100. Okay, so just remember to round down or to round up. So, okay, so you can pause now and then we'll kick off and go through the results. Right, okay, so I think that's enough time if you have paused the video. So the results are here. So as you can see, you should have had similar results to this. Apologies if I've made any errors here, but those are your percentage differences. And then if you add all those differences together and you divide it by 7, then this person has a 19% difference, which is below the threshold of 20%. Although it's very close, it's still below that 20%. So that's how you would approach the scenario of working out peak expiratory flow rate variability or mean altitude. So now we're going to move on to 5 to 16. Again, we can be a bit quicker here because there's actually not that much in the way of differences, but it's important to know the differences. Again, based on the age, you could be asked those very similar questions. What do we do first? What do we do if there's no bronchodilator reversibility therapy? What do we do if the bronchodilator is negative, peak flow is negative, and so on and so forth. So generally, you start off with FeNO. The threshold's lower, it's more than 35 parts per billion. You then move on to bronchodilator variability. Again, it's the same, it's 12% plus 200 or 10% of the predicted. Peak expiratory flow rate variability, again, only do that if there's either BDR is unavailable or it's delayed. And finally, you're doing a skin prick test for house dust mite and you're looking at total IgE plus a rise in eosinophils as well. So if we look at the algorithm from NICE, this is what we do. We look and see, is the pheno high? If it's not, or it's not available, then we look at the reversibility. Again, sorry, I said 200, it's not 200. It's just 12% or more from the baseline in children, so that's an error on my part. And then, of course, it's 10% or more of the predicted normal is the alternative way of looking at that. Then we look at the percentage, only if there is a problem with the BDR. Otherwise, we just go straight to the final step, which is looking for either sensitization from house dust mite, and if there is sensitization, you can make a diagnosis. If there isn't, then you look at total IgE. Is that high? If it is high and the eosinophil rate is also high, then again, with a suggestive history, you can make a diagnosis. And finally, the most important one probably to think about when it comes to actual day-to-day practice, and there's a big cohort of patients that I'm sure you will see in general practice, where you see the under 5s who have a strong history suggestive of asthma, often lots of viral-induced wheezes or admissions with wheeze, usually on a PRN salbutamol inhaler, and parents are looking for that formal diagnosis of asthma. So you can imagine a case like that for the SCA as well, and we actually have run a similar case with our trainees. But if you look at it from that perspective, what you have to remember is that under 5s you can't make a formal diagnosis, therefore the diagnosis, or well, you can't make a formal diagnosis through investigations, but you can use trial of treatment to support that diagnosis. So what you do is you start off with an 8 to 12 week trial of a twice daily low dose ICS. If they have an improvement, then you ultimately stop or consider stopping. And I think that's a risk-benefit discussion as to what the impact of stopping is going to be on that child. But ideally, you probably will want to stop for at least a 3-month period, and then you want to re-review. Now, if there's been a recurrence, then you restart the medication, and then you consider again at 12 months whether you take the child off to reassess the situation. And at every stage you want a salbutamol inhaler to be there. Now if somebody is having that regular low dose ICS and they are still having symptoms, that's the stage where you're thinking about adding in Montelukast for an 8 to 12 week trial. Of course, in children and adults, always remember those neuropsychiatric warnings from the MHRA when it comes to the use of Montelukast. So the thing that I would say to parents often when counselling on the use of Montelukast is just keeping an eye out for nightmares or changes in their mood, and if those are present, then looking at stopping the medication. So again, just thinking about when you may want to refer the patient onwards as well. So generally, at that final stage, if there's no improvement, then you would refer. But often what you tend to find in natural practice is these patients will already be under the care of a paediatrician because they've probably had some degree of admission into hospital with their presumed asthma presentation. Okay, let's move on and just talk about some key management considerations. So again, if you want to pause and you just want to reflect on the different things that we've discussed on the diagnosis, but hopefully it just gives a bit of an insight into how we approach guidelines and the types of things that we'd like you to take away when preparing for the exam. And you can apply this strategy to all of the guidelines that you go through. But if you can get your understanding of these guidelines as secure as possible, actually you can predict what type of questions might come up in the exam, which I think is the best way to prepare for the AKT. So if we think about key management considerations, what's actually changed when it comes to asthma management? Well, one of the things that we know is that for people over the age of 12, we want to be SABA free. We don't want to be using salbutamol at all, really, unless they're established on it and they're not coming off it. But generally speaking, we want to reduce those risks of salbutamol overuse, which is a real problem in general practice. We know that there is the new therapy of what we describe as air therapy, so anti-inflammatory reliever, and of course MARC therapy, which comes in the form of an ICS and formoterol prescription, and generally speaking it's budesonide, which is the medication that we use. Of course, licensing is a problem, especially the licensing of MART in under 12s just doesn't exist, and of course there are different types of inhalers that can be used. I personally generally go for Symbicort Turbohaler, but here are a few examples of what can be used. And when it comes to understanding inhaler therapy, again, you might think, actually, how could that be tested in the exam? But you could be tested on AIR therapy in terms of how is it meant to be delivered to a patient. So, for example, if somebody is on air therapy and they have an asthma symptom, then they're meant to use 1 puff as required. Now, if a few minutes later, generally between 1 to 3 minutes, they're still having symptoms, then they can take another dose, and you can do that to a maximum of 6 doses in one go. Really, if you get into that point, they need to be thinking about seeking further medical advice anyway, to generally a max of 8 in a 24-hour period. Now, the inhalers do in the BNF say that you can use up to a maximum of 12 of certain inhalers for a limited period, but generally, if you get into that need of 8 to 12 in a 24-hour period, there should be some further medical input there from a general practitioner at the very, very minimum. Now, MART therapy is where you use the same inhaler for reliever and you use the same inhaler for regular maintenance use as well. So again, a typical regime would be 1 dose twice a day as your regular therapy, and then if you were to have a symptom, you would then take 1 extra puff, and then again you can repeat that 1 puff later, 1 to 3 minutes later. But then again, a maximum of 6 in a go, generally a maximum of 8 in 24 hours, with some saying that you could use a maximum of 12 for a limited time. So that's ultimately how you differentiate now between air therapy and MART therapy. And again, that's really, really important to understand, because that is a change in the guidelines. And actually, thankfully, there's a unified guideline, not 2 different guidelines like we've had in the past. So now let's think about newly diagnosed management. Newly diagnosed management in a 12 plus patient. So again, it's a relatively simple algorithm that you have to remember, and we're going to come to testing you guys on this through some scenarios in just a short while. So when it comes to symptom control, just think about it's going to be an AIR therapy, so air therapy. But what constitutes poor control? So when you're thinking about poor control, you're either thinking somebody who's needed oral corticosteroids, or somebody who's having regular symptoms. So if they're using their reliever more than 3 times a week, or they're using their MART for relief more than 3 times a week, or they're waking through the night even once, that generally constitutes poor control. So they need to be escalated up that management plan. So again, air therapy to begin with, and if they're needing that inhaler regularly or they're waking through the night, then you're going to switch them to a low dose MART. Then you're going to go to moderate dose MART, and this is where it gets interesting at this next phase. At this phase, you take a breath and you do their eosinophils and you check their FeNO. And if their FeNO or eosinophils are raised, then you refer them to a specialist in asthma, because at that stage you need to be thinking about whether they're going to be eligible for biologic therapy. And I've got a case on this in just a moment. And then finally, in that last stage, you then, if either that's happening and you're waiting, or of course they've been referred and they're not eligible, then that next stage of therapy comes in. Or if both of those things are negative, then you think about a trial of Montelukast, and that's generally an 8 to 12 week trial. Again, counsel for those neuropsychiatric reactions. If they respond to the Montelukast, then continue. If they have a minimal response but a response, then you can continue and add in the next treatment, which would be the LAMA, and you could have tried the LAMA at that stage as well. So ultimately you can switch between the two. You either go Montelukast or LAMA. If Montelukast is helping and you haven't tried the LAMA, then you can add it in if you need that additional benefit, or if it's not helping at all, you just use the alternative. So if you went with Montelukast first, then you just switch to the LAMA. Now if you did it the alternative way around, where you went with the long-acting muscarinic medication like Theophylline, then you start with that medication, you monitor the response over 8 to 12 weeks. If it gave a good response but not quite enough, then you could add in the Montelukast. If it made no difference, you stop and just switch to Montelukast, and that's how you do it. Or if it gives a good response, then you just continue with that medication. Okay, so that's the algorithm. I will put that into practice in just a moment. For children, it's slightly more different. So when I say children here, I'm talking about the kind of 5 to 12-year-old patients, because the guidance is essentially starts at the same point, which is a low-dose ICS twice a day plus salbutamol. But what it goes on to then say is that assess their suitability for MARTs, right? Will they be able to manage a MART regime? Now, the difficulty that you have there is that actually MARTs are not licensed in under 12s at the point of recording this webinar. So therefore, generally that step would come from somebody who's willing to prescribe on an off-label basis. So you're either going to have an interest in asthma or respiratory medicine, or it's going to come from a pediatrician, or you've built up enough clinical competence and confidence to go down that route. Now, the second route is without the MART, and I've recognized and put both onto this slide. But the thing that you have to remember here is what's going to happen in the exam. Are they not going to ask me about this at all because there's two different sides to the algorithm? Or do you have to take the information that you're given to make the decision? And I'm going to show you that a little bit later. But I would say often, if there is two sides of the algorithm, it's very unlikely that you'll be tested on that initial stage of what do we do after the low dose ICS, which is step 1. So you're likely to either be tested later on, or the question itself will be worded in such a way that you know which way of the algorithm that you have to go. So it's always worth knowing both sides, and that's an argument that we used to have when there was a separate BTS sign guideline and a NICE guideline for asthma. Okay, so now we're going to do some diagnostic scenarios, and then we're going to move on to some management scenarios, and then we'll have some time for stats as well. Okay, so you have a 28-year-old patient here who presents with intermittent wheezing, shortness of breath on exertion, has known eczema, and has a strong family history of asthma. So the question's kind of worded in a way that asthma is your likely diagnosis. So what to do is just pause the video and just answer these questions. So just think about the diagnostic phase. And what I'll do is I will then go through the answers with you in a bit more detail. Okay, so let's go through each one of the answers now. So the first question that I asked you was, is there anything else that you want to know before making the diagnosis? So occupational asthma is a real hazard, it's a real risk, and you should always think about it, especially in people who are presenting with first time symptoms in adulthood. So always ask about occupation. So that should have been your first answer. Again, slightly different, a bit of a tangent to what we've covered so far, but it's always worth building in that extra knowledge from the guidelines. Now, the second thing that we need to think about is, okay, so first line investigations, it's either going to be our eosinophils or it's going to be our pheno testing. Now, this question C was what happens if that is negative. So if that's negative, then we're going to go into the BDR testing, which is going to be either 12% reversibility with a rise of 200 ml or more, or 10% from the predicted baseline. And then we're going to talk about the second line treatment. What happens if that's delayed? Now, if second line treatment is delayed, then of course we do the peak expiratory fall and we look for that 20% difference. And finally, the last step would be the bronchial challenge test. Okay, and this is the slide that we covered earlier, and this is the explanation from the NICE guidelines as well. So we're now going to ask the similar question, but this time for a pediatric scenario. Okay, so have a look at this question. So sorry, this should have been a child, so rather than 28 we'll go to 8 years old. So you've got an 8-year-old patient this time. Again, same scenario, just think about the diagnostic phase for the 8-year-old and how you would respond to this from questions A to questions D. Okay, so if we work through the answers for this 8-year-old child, then the first line investigation or the expected results would be a pheno of more than 35. If that's not the case, or of course the If that's not the case, then we go on to B. So B is going to be the BDR with the 12% reversibility or 10% increase from the predicted for that child. If C, we're going to move on to peak exposure flow rate, and D is again where it's different to the other algorithm, which is a positive skin prick for house dust mite, or they need to have a raised IgE and a raised eosinophil, and all of that must be in line with a history suggestive of asthma. Okay, so you can see, rather than just giving you kind of multiple choice questions, which is typically how the AKT is going to be assessed, there's a lot of benefit in terms of trying to do these questions purely from the basis of knowing and trying to figure out the answers without having just those STEM based questions, which is what you'll get used to when doing the question banks. So again, the difference being with the adult algorithm is that there's no eosinophils initially, and of course stage 4 is different. There's not a bronchial challenge, it's the skin prick testing and then total IgE and eosinophils. So again, here we have our nice algorithm as well. Okay, so now we're going to move on to some asthma management scenarios. So let's now test our understanding of asthma management, and again, this is what we're going to do in our live sessions. We're going to try and then unify those concepts that we've covered. So here you have a 26-year-old non-smoking female patient, and I will give you 2 minutes. Well, I'm not going to give you 2 minutes. You can pause now, and I'll then go through the answer with you. Okay, so now time for the answer. So the answer for this patient is relatively straightforward. You've made a diagnosis of asthma, they've got a raised FeNO, and you can start as required therapy by the anti-inflammatory reliever, which is generally going to be a low dose ICS with formoterol. Then we've got our second scenario. Okay, so now that you've had time to look at question 2, let's go through the answer. So the answer to question 2 is that you would now escalate this patient away from their air therapy towards their MART therapy. And why do we have to do that? Well, they've got frequent reliever use and they've got nocturnal symptoms, and therefore you need to work up the algorithm. We've now got question 3, so again you can pause it and we'll then go through the answer. So now that you've had some time to look at the answer, the answer to this question will be that we need to check the FeNO and eosinophil count for this patient. The reason why we need to do that is we need to think about whether or not this patient's going to be needing referral or whether we can optimize the medication ourselves. So because they're on the moderate dose moderate dose MART therapy, we then need to think about whether or not this patient is going to need either biologics through the asthma specialist, or whether or not they're going to need either leukotriene receptor antagonist or they're going to need treatment with a long-acting muscarinic agonist. Okay, and finally our last adult scenario before we move on to some children, some scenarios for our 5 to 12-year-olds. So here you've got a 50-year-old man, and I will just pause or allow you to pause and then we'll go through the answer. Okay, so now that you've had time to pause, the answer to this question is that you will add a long-acting muscarinic agonist, so Tiotropium, to his medication. Apologies, I think I may have said Theophylline earlier when talking about the LAMA, so I do apologize for that. So in terms of using the long-acting muscarinic agent here, so you've got some partial benefit from montelukast, but they're still inadequately controlled. So therefore, if there is partial improvement, there's no need to necessarily stop it, although you can have that risk-benefit discussion with the patient, and then of course you can add in that additional medication to see if you can optimize their asthma management further. Okay, so now we're going to move on to talk about some scenarios for children. So again, it's just 2 quick scenarios and then we're going to move on to some of our statistics based learning. Okay, so if we start off here, again pause, and we'll then go through the answer together. Okay, so if you look at the answer for this question, the reason why I built this one up was so that you will then see how you're already on the MART pathway, so the patient's already on MART therapy, and therefore if they're on the MART therapy and they're on low dose MART, then the next step would be to go to a moderate dose MART. Okay, and if we look at this one, so this patient's not on MART therapy, so if you again pause, have a think about the answer, and then we'll go through the answer together. So this is the answer to this question. So what we're going to do is we're going to stop the low dose ICS monotherapy. We're going to switch to a low dose ICS and a LAMA combination, but we're going to continue with the Montelukast. Again, risk-based discussion about continuing with that, but again, similar to the adult scenario, there's been a partial response to Montelukast. The control is still not optimal, and therefore the next step would be to go down the pediatric algorithm and add in the LAMA and ICS combination in addition to that Montelukast, and therefore you're going through the stepwise escalation plan. So again, it comes down to this traditional algorithm on this side, which is going to that twice daily low dose ICS LAMA combination. If that doesn't again provide adequate relief, then you would step up to moderate dose as well. Okay, so I hope you found that helpful. How do you take this away? So this is where we need to talk about how you can further your own application. So if you want to further your own application about asthma guidance, again, look at the guideline yourself, familiarize yourself with what the guideline is saying about asthma treatment, but also think about things like stepping down on therapy for people who have been established, how you might want to switch people who are on existing treatment regimes if they're having suboptimal control, and how you may be able to switch to the newer therapies or the newer algorithms. There's lots of information within the guidelines on that. Also think about occupational asthma and the types of questions that you might need to think about occupationally. Think about the side effects that come with some of these medications. So we talked quite a few times about neuropsychiatric reactions from Montelukast. So again, take all of that into consideration when weighing up your approach to asthma for the AKT. And hopefully, if you found this helpful, then this is the approach that we'll be taking in our live sessions, and this is the type of approach that we've used within our one-to-one AKT coaching as well. Okay, so now I'm going to move on to the second component. So the second component that I want to talk about is statistics. Now, what's the big problem with statistics? Well, the big problem with statistics is that actually, I would return the question actually. Let's say, what's the big benefit of statistics when it comes to the AKT? So the big benefit of statistics is that it's a guaranteed 10% of your exam, and the other 10% comes from practice administration. So if you think about being able to get a guaranteed of close to 10% for the exam, for most trainees that's a make or break, because the clinical curriculum is so vast that it's very difficult to consider everything that could be asked from a clinical perspective. But you can actually predict to a reasonable degree what will come up from a statistical perspective, and it's either going to be working out calculations, it's either going to be your understanding of calculations and what the numbers actually mean, or it's going to be interpreting data, so whether that's incidence, prevalence, probability statistics, or whether that is graphs, which is usually the one that causes trainees the most sleepless nights. And generally the big problem is that if we can read a graph, we often don't understand what the numbers mean, the statistical values, and we get into this kind of repeated pattern that I've seen with other GP educators, which is all about learn the statistics, just learn the formulas, which isn't correct. What you need to do is know the formulas, but also know what the numbers actually mean, and that's what I've tried to prepare for you today. And hopefully we'll be doing this on a week by week basis, just continuing with regular practicing, initially starting off with a bit of theory, but the theory is all on our online course anyway. So the whole idea of this kind of regular session, that 30 minutes of stat, is going to be trying to apply those principles. But for today, just to give you a taster, I thought I'd put some of the principles into the webinar. So I'm going to use the example of falling asleep during a webinar. So what is risk? Like, to understand risk ratio, to understand absolute risk reduction or absolute risk increase, number needed to treat, number needed to harm, it all starts off with understanding the concept of risk. So the risk is effectively the likelihood of something taking place. So let's say we've got 100 doctors today listening to this webinar, and we say 20 doctors fall asleep. So the risk of falling asleep in my webinar is 20%. Now that's pretty bad because that's quite high. But we also can put 20% into a decimal, which is 0.2. So you have to be very familiar for the exam in terms of working between percentages and decimals. So percentage, 20%, 0.2, 10%, 0.1, 100% is 1, 50% is 0.5, 75% is 0.75. So you start to learn about this when you're in primary school. But of course, it's just that reminder that we can work between the two, and start thinking of risk always as a percentage likelihood. So this is 45% likely in this group, this is 35% likely, and so on. And I think once you start working or looking at it like that, it's going to make the exam much easier. So how do we make this calculation? Effectively, we looked at our outcome. Our outcome was people going to sleep. We looked at how many people were in the webinar, and we divided the two. And if you want to convert that into percentage, you times by 100. Otherwise, you just work in decimals. And I would say try and get comfortable with working in decimals. I think it's a lot easier for the exam. And you can apply this to any case. So what I want you to do is pause and come up with your own scenario. Be it treatment, be it somebody falling asleep, being it what's the risk of fracturing your leg whilst playing football. Anything can be a risk. What's the risk of a house burning down? So there could be 1,000 houses in one estate and one burns down. So the risk of your house burning down then from that example relative to that cohort of houses would be 1 divided by 1,000. So that's how we think about risk. Why is risk important? Well, if we think about groups, whenever we're doing a study, we're generally comparing two groups, right? One group that is our control group. So a control group might be a placebo group. It might be somebody who's having conventional treatment, so let's say metformin for diabetes, where somebody might be having experimental treatment for diabetes, like a GLP-1 analog, right? A new therapy, and you're trying to compare the two groups. So the metformin thereby becomes the control, and the GLP-1 becomes the experimental. In our example of people falling asleep, I might offer every single one of you a shot of coffee, and coffee becomes the experiment. Is coffee likely to reduce how many people fall asleep during Sham's lecture? That's the question that we're asking, right? And I'll come to that in just a moment. So what the problem becomes is that you never have the same number of people in each group, right? So you could have 100 people who have no coffee, and you can have 50 people who have coffee, because 50 people just don't want to be in the study because they don't like coffee, or they have an allergy to coffee, or they get palpitations with coffee. So you can see that how in our studies the groups are never equal. So therefore, to standardize groups, we convert into percentages or decimals for that matter. Now, all of this is then coming into what's called a risk ratio. So a risk ratio is basically a very easy tool to compare the risk of one group relative to the risk in the other group. So if we take our coffee sleeping example, what I want to work out is what is the likelihood, or what is the benefit of giving people coffee during my lectures, because if they stay awake, then I might think about investing in a regular shot of coffee for that person, right? So if I then think about the risk of people falling asleep without coffee, and that worked out to be 0.2%, so that was 20 people falling asleep out of 100, and then in our experimental group there might be 2 people, but this time the group contains 200 people, right? So in the coffee receivers, the risk was 0.1%. 2 divided by 200 would give 0.1, right? Which would be 10%. So we've got 10%, 20%, 0.1, 0.2. So what I want to work out is how do I compare these numbers, and the way that we compare is we work out a risk ratio. Now the thing is, the reality is you don't even need to work out the risk ratio. You already know that coffee is better. Coffee is better because the risk is lower. It's 10% compared to 20%. So you already know the answer. But for the sake of the exam, you need to understand what risk ratios mean, and you're going to need to understand what risk ratios mean when it comes to dealing with graphs. And I'll show you a graph a little bit later, because it's the same with odds ratios as well. So if a risk ratio is 1, it means that there's no difference between the two groups. So if we did 0.1 divided by 0.1, it would give us an answer of 1, which means that there's no difference. If we have a risk ratio of less than 1, which we have here. So if we did 0.1 divided by 0.2, it gives us a risk ratio of 0.5, which is less than 1. So what that means is that coffee is helpful. It stopped people from going to sleep during Sham's lecture. However, if those numbers were turned upside down and it was 0.2 divided by 0.1, then our risk ratio would be above 1, which would have meant that coffee makes no difference. If anything, coffee increased the likelihood of people going to sleep. And this is all what we do. This is everything that we do when we work with these statistics. We're looking at how it influences relative to from one group to the other group. Okay, and again, we go through this in so much detail within our online course that I don't think you need to spend too much time worrying about that specific point. But the point that I wanted to make was that we think of ways to simplify how to approach statistics in the exam. And I teach this kind of 5-step, multi-step calculation when it comes to, and I'm going to go through an example with you, or you can go through that example yourself. But I want you to note these steps down. Step 1 is work out your experimental rate. So how many people fell asleep with coffee? Control rate, how many people fell asleep without coffee? Risk ratio, the coffee group divided by the non-coffee group. Absolute risk reduction. So yeah, as long as the outcome is being reduced, we use absolute risk reduction. If the outcome is increasing, we use absolute risk increase. I'm just focusing on absolute risk reduction just for this slide. So because we know that coffee is helping, then we take answer 2 and we minus it by answer 1. If it was absolute risk increase, we would just turn it around. And then finally, we talk about number needed to treat. And the number needed to treat is basically the number 1 divided by the number that you got from answer 4, which is 1 divided by the absolute risk reduction, would give you number needed to treat. Now, with number needed to treat, even if it is below 1.5 or it's below 0.5, you always round number needed to treats up, and you always round number needed to harms down. So let's say you had a number needed to harm of 1.9, you would never go to 2, you would still round down to 1. And if you had a number needed to treat of 1.2, you would still round up to 2 rather than rounding down to 1. Again, we go through this in much more detail, but I'm just doing it for the sake of this webinar. So here's your question. So I've made it slightly easy for you guys because I've given you the experimental group. Okay, so the risk in the experimental group, so your experimental event rate has already been counted for you. It's 0.18, which is 18%. So you already know that A is going to be incorrect because that's saying 80%, which would have been 0.8. Okay, so again, pause the slide and then we're going to go through the answer together. Okay, so in terms of going through the answer together, the answer to this question is E. So it's the number needed to treat is 2, which means 2 additional people need to receive mometasone nasal spray to protect them from having a post-viral cough. Okay, so that's a good thing, right? It means that a low number needed to treat is generally a good thing. It means that the treatment is fairly effective. Okay, so how did we work this out? So the way that we worked it out is that we already knew our experimental event rate, which was 0.18%. We could work out the control event rate because in our control group we had 450 people that received a placebo. We had 360 people in the control group that experienced a post-viral cough, and therefore we do 360 divided by 450, which gives us the control event rate at 0.8 or 80%. We can work out the risk reduction by doing the experimental event rate divided by the control event rate, so answer 1 divided by answer 2, which gives us 0.23. We can work out the absolute risk reduction, which is answer 2 minus answer 1, which is 0.62, so 62%. And then we can work out the number needed to treat, which is 1 divided by answer 4, which gives to 1.6, and that can be rounded up to 2 as our number needed to treat. And if you kind of go back through that question, so if we kind of work through each one, well, we know that the experimental event rate is not 80%, it's 18%. Sorry if that wasn't clear in the first explanation. Of course, the control event rate is not 82%, it's 80%, which we've calculated, 0.8. The absolute risk reduction, if we go back to that slide, it's 0.62, so it's 62%. Are people more likely to experience a post-viral cough? Well, we know that's not the case because our risk ratio was 0.23, so it's less than 1, and less than 1 means it's less likely. And then finally, the number needed to treat, so 1 divided by answer 4, which gives us a round number of 2, which means 2 additional people are likely to benefit, which is how we came to our correct answer. So I hope you found that helpful. Again, it's a whistle-stop tour of statistics, but what I want you to do, and what we do with our coaching clients, is we encourage you to go through the course, build up that fundamental knowledge, and as you can see from the feedback I showed you earlier, people are getting 18, 19 out of 20. We've helped people increase their scores by up to 40% just by applying this framework and just then practicing ad nauseum these regular calculations, so that you not only understand how to do the calculations, but you're understanding what the values mean. Okay, now final point, I'm just going to finish off with a graph before we come back to how you can register for this if you would like. So here we have a funnel plot. I'm sure you've maybe come across a funnel plot before. So what is a funnel plot? So generally, and I can say this with some confidence, when trainees come to us and I ask them what their understanding of a funnel plot is, most of them will say, well, okay, it looks for publication bias. How do you look for publication bias? Well, if the graph looks different, if it looks irregular, then there's publication bias, and that's correct. But actually, our questions on publication bias or funnel plots are more understanding, do you really understand what the graph is showing you? And to do that, you need to understand some fundamental principles. So one principle that we always have to talk about is what is actually being measured at the bottom. And hopefully, if you do join us, I'll go through lots of different examples on funnel plots. But at the bottom of a funnel plot, you are effectively plotting individual studies, right? So here's a study, there's a study, there's a study. All these dots are studies, and you plot them on the x-axis by their result of their study. What did they measure, and what was their overall measurement from their study of their combined result? And then you measure that on the y-axis against standard error, which I'll come to in a moment. So here you can see it says log odds ratio. So an odds ratio of less than 1 means it's less likely. An odds ratio of more than 1 means it's more likely. An odds ratio of 1 means there's no difference. Exactly the same as risk ratio from that perspective. So here, when you're looking at a meta-analysis which combines all of the results, this solid line in the middle means the overall effect. When you combine all of those studies together, what did we get? So our overall effect is around 0.4, let's say. So we know that this study was helpful in reducing the outcome that it was studying. Okay, so that's how we use the x-axis. So it can be risk ratio, it can be prevalence. I've got a really good example about prevalence actually, because prevalence is just a percentage, right? It's how many people have something within a community. So again, even percentages can be on this x-axis. And then on the y-axis, it basically just means the good studies or the bad studies. So the best way that I or one of the ways to think about this is cream rises to the top. So if you've done a really good study, or you've included a really good study, then it's going to be at the top of the pyramid, because that's the one or the top of the chart, because those are the studies that are going to rise to the top. Whereas your really bad studies are a bit like a very hard stool, which is not good. So they're going to float to the bottom of your basin. So that's one way of remembering it. Cream rises to the top, stool floats to the bottom. So all of these studies here are of poor quality. They're not very good. They have a high standard error, whereas the ones at the top, they have a low standard error, so they're very, very good. Okay, so to demonstrate this point, I've got this question for you. Have a look at it. I'll go through the answers with you in just a moment. There's 3 correct answers here. So you've got 3 correct answers. So I would say it's a fairly easy one now that I've told you that there's 3 correct answers. Of course, that won't happen in the exam. Again, these sessions are not built to replicate everything in the exam. What they're built to do is give you solid foundational principles that you can then apply in the exam. So what I'll do is, again, pause it, have a go at it, and then we'll go through the answer. Okay, so yeah, I hope most people got this right, in the sense that there is publication bias here. The one that would have been wrong is to say that there's no publication bias. Why? Because you can look at it and you can immediately see that there's not symmetry in the graph. But actually what I want to focus on with you guys is understanding what the study is actually looking at here. So you've got a systematic review, so it's compiled lots of studies together to compare the effect of bisoprolol on congenital abnormalities. So if somebody takes bisoprolol in pregnancy, how likely is that their fetus is to develop congenital abnormalities if they're exposed during that first trimester? So if we look at that number at the bottom, this is going to be looking at odds ratios, okay, because of the type of study is, but it could be risk ratio as well. But if we look at it from that perspective, if I've got this right, an odds ratio of 1 means no difference between the 2 groups. An odds ratio of more than 1 means that bisoprolol is more likely to cause a problem, and an odds ratio of less than 1 means that bisoprolol is less likely to cause an issue. So if we then look at it from this perspective, low quality studies showing the benefit of bisoprolol have been included. That's correct, because these studies, because they're all less than 1, they're all showing the benefit of bisoprolol, right? All of these studies on this side of that solid line show the benefit. Now, of course, we've got a selection of low quality studies, right? You know, the stool floats to the bottom. So these are all your low quality studies. Now, what's missing? The low quality studies that show the harms of bisoprolol, or generally studies showing the harms of bisoprolol, which would be above 1, are missing, aren't they? So we say more studies showing the harms of bisoprolol have been excluded from the meta-analysis. Therefore, this combined result that we've got here, this dashed line, is likely to show some degree of error or publication bias. So here you go. We talked about odds ratio, 1 no different, less than 1 supports the use of bisoprolol. And again, these are just artificial scenarios, by the way. They're not true scenarios. Don't quote me and go give your pregnant patients bisoprolol. And then of course these are increasing the outcome on this side. So if we had a true study, one without bias, then we would have had the graph at the top. That's the one that we would have wanted to see, not the graph that we saw, which was the one on the bottom. So now you see that there are studies showing the negative benefit, the negative effects of bisoprolol, which is where bisoprolol would have increased the outcome of congenital effects. Okay, so just over an hour, probably a little bit more given all the pauses in between. So I hope you found that helpful. The study sessions, as I said, will be starting for candidates wanting to prepare from October. So if you're wanting to prepare for the October 25 exam, then your live sessions will be starting in August. You will get access to all of the online material before then. So that is the benefit. You can get yourself familiar with all of the pre-recorded material and then really refine your understanding of guidelines, refine your understanding of application, refine your understanding of statistics through the regular one-to-one sessions. There will be 12 sessions. We won't be doing them every week, so there'll be a couple of weeks where we'll have a break as well. Just I appreciate there is summer commitments. Weekly recordings will be available for the duration of your exam revision time, so that will be per sitting. So if you sign up for that cohort from October, then you'll get access to the recordings until that October sitting, so you can then re-review and re-watch the sessions as well. and try some of those examples, similar to the examples that we tried today when it comes to stats and graphs. And hopefully, as you become more comfortable, the number of examples will increase as well. So what does that all come to? As I mentioned earlier, our online course is £120. So all of this, the access to the live plus the online access, will come to £300. So we feel it's a relatively good value at £10, less than £10 an hour ultimately, or sorry, around £10 an hour is what you're paying for the live component. So if you do want to sign up, there is a registration form in the description. You just click onto that, pay your deposit, and we'll be in touch via email. As I said, it is 50 spaces, so it's fairly limited. We anticipate that we will be full. Of course, if we are full, there is still a opportunity to be added to the waiting list, and depending on demand, we'll then look at releasing a second cohort. If you have any questions, by all means leave us a comment, and one of us will get back to you. Or of course, you can send me an email at sham@wellmedic.co.uk. I hope you found this helpful, and I hope you found what we do at Wellmedic to be useful as well. Thank you for listening, and please do give us a thumbs up on the video as well, just because that will help with whatever social media algorithm we need to try and keep on top of. Thank you.